Now I am going to discuss the treatment of Candiduria with systemic antifungal agents. Generally, no treatment is needed for most patients with Candiduria who are asymptomatic. Treatment in such groups or in such patients is only recommended if they belong to high risk groups. For example, patients who have to go urological procedure, they should be administered antifungal agents few days before and few days after the procedure. Antifungal agents are also indicated in infants with very low birth weight and in neutropenic patients. Treatment is indicated for kidney transplant patients if they have evidence of obstruction or they have to undergo a planned urological procedure such as stent removal, or they have signs of infection. What is the management in asymptomatic patients who are in non-high risk category? If these patients have any indwelling catheter, it should be removed if possible. If catheter cannot be abandoned, then it should be replaced in order to reduce Candiduria. If a patient has any obstruction of urinary tract and Candiduria, then obstruction should be removed because it is essential for long-term eradication of Candida from the urinary tract. Treatment in symptomatic patients. If patient is having upper urinary tract or lower urinary tract symptoms and their urine culture is growing both Candida and bacteria, then they should be treated with antibacterial agents first. On the other hand, if culture is growing only Candida species, then antifungal agent should be used first. The antifungal agent of choice is oral fluconazole. It should be administered in a loading dose of 400 milligram and then it should be continued in half the dose of loading dose for 14 days. Limitations of oral fluconazole is that it is ineffective against Candida cruzi and some species of Candida glabrata. What is the role of IV amphotericin B deoxycholate in Candida UTIs? It is effective for upper tract infections or in cases of fluconazole resistance. The dose of Amphotericin B is 0.3 to 0.6 milligram per kg per day for 1 to 7 days. It should be extended up to 2 weeks in complex cases. The side effects of amphotericin B deoxycholate include nephrotoxicity and infusion-related reactions, which may manifest as fever, rigors, nausea, and headache. Lipid formulation of amphotericin B is not effective in Candida UTI. Fluconazole interactions. Fluconazole increases the serum concentrations of phenytoin, warfarin, cyclosporin, tacrolimus, and sulfonylureas. In addition to that, fluconazole should be used with caution in QTC prolonging medications. Other azole agents like itraconazole, voriconazole, posaconazole, and isavuconazole are usually not recommended and have limited evidence of effectiveness. Role of flucytosine for Candida UTI. It is alternative to fluconazole. If fluconazole is not tolerated or Candida is resistant to fluconazole, the dose of flucytosine is 25 mg per kg orally every 6 hours for 7 to 10 days for patients with normal kidney function. Flucytosine is effective for most Candida species except Candida krusei. If flucytosine is used alone, resistance emerges quite rapidly. What are the adverse effects of flucytosine? The major adverse effects include bone marrow suppression and hepatotoxicity. These adverse effects increase in patients with kidney failure. Echinocandins for Candida UTI. Echinocandin antifungal agent group include caspofungin, micafungin, anidulafungin. There is minimal to no active urinary excretion. Tissue levels of it may suffice for invasive infection, but effectiveness is inconsistent. Currently, echinocandins are not recommended for Candida UTI, and they should be considered a last resort in cases of Candida glabrata UTI if other treatments fail.